Hey, Mario, are you there?
Yes, I'm here. All good?
How you doing?
I'm fine. I'm fine. I'm fine.
You hear me?
I have so I think there are many who send me
Mario, can you
messages.
hear me?
Yeah, I can only see the starting
I
soon
can't hear you,
screen.
Mario.
Can you hear me? Can you hear me?
Can't hear you. Can you hear me? Yes? I cannot
Yes.
hear you.
Let me try to come out and rejoin. Yep.
Okay, hold on.
Hello, folks.
Can I get my?
Can you hear me, Yao?
Yeah, I can hear you fine. I'm just gonna get my video on.
Perfect.
Is my
John, can
video
you hear me
working?
now?
I can hear
Mario,
you
can you hear
perfect.
me now?
Yes.
I hear you both.
Hello, yeah.
Hello, sir. How are you?
Okay. I can't hear you. Testing,
Really?
1, 2, testing. Testing,
I
1,
can hear
2.
you both.
Hello, can you hear me?
Yes, I can hear you. Yes.
Okay, I cannot hear you.
Is there something wrong with at your end? Because I can hear Mario. The chat's disabled, isn't it? Mm.
Hello, testing, 1, 2. Testing, you can hear me, but I can't hear you. Testing, 1, 2, testing, 1, 2. You can hear me, but I can't hear you.
I can hear you perfectly. I can hear you perfectly, John.
Yes.
Okay, I can see your microphones are on.
Yeah. I think it's at your end.
Hello, testing, 1, 2, testing.
Can you hear us?
Yeah, now, yeah.
Yeah, it was your headphones, I think.
Yeah, there we go. There we go. Okay, yeah, are you a resident or attending?
Resident.
Resident, what year?
I'm basically at the end of my everything, basically.
Oh, okay. Mario, how are you doing?
Working a lot, John. Working
Good.
very much.
Okay, let's get this done.
So
We'll communicate better next time.
yeah, that's fine. That's fine. The first speaker is about to join. He's just send me a text.
Okay, Ya is going to be introducing. I'm going to introduce you first, Ya, and you introduce Mario.
Mhm.
Okay. You take it from there. After I
And then
introduce,
we'll take it from there. Yes.
yeah, you take it from there. Introduce Mario, and then you'll be introducing. You'll be taking questions. I don't know how you want to work it, Mario. You want to have them take questions after the presentation, or wait to the end, or?
We will take a question after each presentation because Itesh needs to leave at
Okay.
1 p.m. So basically, whichever question we have for him, we'll answer them immediately. Otherwise, we'll move on with the other talks.
Okay. Well, basically, Ya will run the show. Basically, after I turn it over to him. Hello, Nick. How you doing? From Greece.
Good evening, everybody. Greetings from Thessaloniki, Greece. It is a very great honor and great pleasure to be with you because the organizer of this webinar is Dr. Mario Ganau, estimated colleague and a great friend since many years. With Dr. Ganau, we were residents in the University of Verona Neurosurgical Department 16 or 17 years ago. And it also great pleasure to see you also, you dear friend John. And one of the speakers is also one of our estimated colleague from Georgia, Dr. Jakob Tsetsevadze.
Jakob should be already here. Yeah,
yes.
Jakob is here. Can we move him to, and also Ayush is here. Can we move them as
Yeah, sure.
panelists?
Okay.
Uma,
Jakob,
Thank you
Ayush.
very much.
and who was the other one?
Jakob and Ayush.
Oh, Jakob. Okay, yeah.
And Nick, if you stay in, I will ask you some question. I will let you talk a little bit. Okay.
Okay.
Okay, I will be here.
If you're happy to remain as panelist, I'm more than enthusiastic about having you.
I'm not seeing Jakob. Where is?
Jakob is now should be one of the panelists, and Ayush Sharma also should be moved as panelist.
Okay, Yusha is coming in. Hello, Jakob. John Bennett, welcome.
Hello.
Hello, Uma. Is your camera
my colleagues.
working? Uma, you working? Your camera working? Uma. Ayush, your camera's working, obviously. How's your microphone, Ayush?
Can
Okay.
you hear me? I'm audible?
Okay. No, you can hear me okay, right?
Yeah, I can hear you loud and clear.
Okay, good. And Uma, could you check in, please? She may have stepped away.
But she's not giving talks, so it's not necessary that she's here.
Okay. Harshad, good morning. Are you in the hospital, Harshad?
Yeah, hi, good morning. How are you?
Hello, Harshad.
Hi, how are you?
Good or good?
Good.
How are things in India?
Oh, very hot weather.
Good.
Thanks for joining.
Yeah, it's my pleasure.
Do you want me to check my presentation once?
If you want to, sure. We have a few minutes.
Better to, check once. Can you see it?
Yes. Okay, perfect. That's the
So I
presentation
would like
mode.
to.
Do you
You
have
can
any
see the-
video? Do you have any videos?
Yeah. Can you see the video?
No, I could see the presentation perfect. So go to your video. Okay. Yeah, it looks good. The video looks good.
Look amazing.
All good? Yeah. Okay, fine. Then
Yeah, it looks good. We can see it fine.
Yeah.
So I would like to check if it's possible.
Yeah, go ahead, Jacob. Jacob, go ahead.
It's okay?
Okay, put it on presentation mode. Do
Sorry.
you know how to do that?
It's okay?
Perfect. You got it. You got it.
Working?
That's
Yes.
good.
Okay, thank you.
That's good. Anybody else want to check?
I do not have Itash yet.
Do we have everybody missing?
We have a few minutes to before we start broadcasting.
Yeah, about 6 minutes. 6 minutes. Well, Hitesh is not here yet, right?
Let me call him.
Yeah, Hitesh is not here. Not here. Okay, let me check on put. Are you in contact with Hitesh Dabasia? You know, have you heard about the Oxford Scholar? Let's see, the Oscar Scholar Program used to be famous when I was younger. They would give Oxford scholarships to anyone in America in college that distinguished themselves. They became an Oxford Scholar. You still have that, Mario? Oxford Scholar? Oh, I can't hear you. Can't hear you again. Hello, can you everyone hear me?
Yeah, I hear you fine.
Yeah, okay.
John, the
Mario,
most famous scholarship for U.S. citizen in the UK that wants to visit the UK and come to Oxford is the one from one of the colleges,
oh,
and
okay.
I think
That
you are referring to that one. I believe Bill Clinton came
yeah,
with
I
that
can remember
scholarship.
growing up and hearing people say, yeah, he's an Oxford Scholar. And that's the program's still going, right? Well,
I think what you are referring to is called the Rhodes Scholars.
oh, Rhodes Scholar. That's right. That's right. Okay.
Yeah, that's still ongoing. Rhodes is one of the famous colleges and institution here.
That's from Oxford, right?
Yeah. Is in the city
Rhodes
center and
Scholar.
offers scholarship only to American citizens.
Oh, okay. Yeah, my brother was up for that. He was recommended. I guess have to get recommended first, and they pick the people.
Yeah.
Uh,
I would say if Itesh does not join, shall we start with Ayush first?
Yeah, I'm fine
whatever,
with that. No issues. I
whatever
can
you
do that.
want to do. Whatever you want to do.
If let's see,
I'll
if he's
let
not in,
y'all will pick the speakers and speak to you. Okay, yeah.
Okay, so
Yeah.
I'd just like to say thank you for having us today for this panel on spine surgery. I'd like to introduce part
Oh,
of the
not yet.
chair for.
No, we're not starting
we're
yet.
not live yet.
Oh, sorry,
We'll
I'm ahead of time, huh?
You can
we'll tell you
practice,
when we are
y'all.
live. Yes.
You can practice.
I got it down.
Okay.
You were very professional.
Oh, that's good.
Always.
So you have a huge program there, Mario? Is it a huge neurosurgery program?
Pardon?
Is it a big program at Oxford?
Oxford.
Neurosurgery? Big.
Yeah, is a very big department. Yes.
Yeah. And the Global Neurosurgery Initiative. Okay.
Yeah, this is something that I started with for a project with the American College of Surgeons. Can I ask you, what is now your main channel on Facebook?
My main channel is actually in my brother's name, Kurt Bennett. Kurt
No,
Bennett.
this one, neurosurgical.tv on Facebook. Is it the main channel for you or not?
No, WhatsApp is the main one. That's the social media and Instagram and the website, the Neurosurgical TV. Okay, 1 minute. Okay, here we go. Ready, Mario?
Yes, we are.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. Bennett, John Bennett from Miami Beach, Florida, home of Neurosurgical TV. We are honored to have the presence of the Global Neurosurgery Grand Rounds, directed by Mario Ganau, and I'm going to have Yaw introduce the program, and he's going to start off by introducing Mario. Good day, and Yaw, by the way, is a resident at Oxford. Welcome, Yaw.
Thank you very much. I'd like to start off a thank you for having us today for this spinal round. I'd like to introduce Mario Ganau, who is a consultant neurosurgeon based in Oxford at the John Radcliffe Hospital. He is lead of trauma, neurotrauma, and he's lead of he's deputy training program director within the training within the Oxford Deanery. He has a background of growing up in Sardinia, where he did his medical school. And after medical school and part of his training, he did a fellowship in Toronto based on complex spine surgery. He also has PhD studies in nanotechnology and biomedical engineering, and that has improved his understanding of spine itself and the management of spine. He has various initiatives with educational bodies such as the EANS, and he's had some collaboration with the American training programs as well. And he was a visiting researcher at the Kennedy Institute of Ethics in Georgetown University. He has a far more distinguished background than I can describe in the short time we have today, so I had to stop there. But he is kind enough to organize our talks for today. Okay, so my understanding is we have two of our colleagues ready to give us talks today. We're going to start with a gentleman called Jakab, who is going to tell us how he operates on extrafemoral number discs, herniations, and he is based in West Georgia in a medical center in Cortese, Georgia.
Yeah. Let's start with Ayush instead. Let's start with Ayush.
Oh, Ayush, sorry. Okay, sorry. So we start with Ayush, who's given us interesting talk on MRI navigation in spinal surgery and talking about the newest frontier involved in this. Thank you.
Should I?
Ayush, yes, prepare your slides. Ayush is the head of spine surgery in Mumbai. Is a very known AO spine faculty speaker. So we're all waiting for his talk on neuronavigation. Ayush, please, the floor is yours. Thank you.
Thank you so much. It's an honor and a pleasure to be here. And we all know navigation. It is nothing new. You use it every day. We all use Google Maps, the Apple Maps, and whatever you need. And navigation in spine or neurosurgery is nothing new. We have been using it for many, many years. And, typical spine navigation, this is how it looks like. But look at the problem with spine navigation. When you are dealing with spine, actually, navigation only tells you about the bone. But 80% of the pathology which you deal with is actually spine cord and the nerves and not the bone. And that is where the biggest challenge comes in using navigation. So when you look at the typical MRI navigation, this is how it looks like. This is too big and the uses are very limited. So with the cost with which it comes and the use it has, it again becomes a dilemma to use a typical MRI navigation. And that is where my talks comes in, MRI navigation, spine surgery, the new frontier. So, and thanks for the introduction. I'm Dr. Ayush Sharma. I'm a consultant spine surgeon based in Mumbai. So, what we did is something different. So this is our typical MRI protocol. This protocol, if you see, patient has to undergo a specific sequencing of protocol and in order to be in this navigated MRI imaging system. And this is how it looks like. So basically, this MRI navigation is a merger of pre-operative MRI and intraoperative imaging system. So the bone scan or the CT scan is real time, but the MRI is pre-op, and the software and AI-based software merges the two, and you can look at its accuracy once it merges, and it is amazing. It is just at a flick of button. You can change between your MRI and your bone scan. So this is what it is. It is nothing which we invented. It was there with the Brain Labs. Only thing we did is started using it. So how do you test something like this? When you are looking at a new technology, you need to test it before you start using it. So what we did is we started testing it on our cervical laminectomy. This is how we started. We started with the simplest of the cases so that even if there is a problem with the system, you are unlikely to make mistakes. This is how a cervical laminectomy setup looks in my hospital. So what I'm doing is I'm navigating my ultrasonic scalpels, and the images allow me to look at both MRI and the bone scan at the same time. So you know exactly what is the amount of laminectomy you're doing, and you are very, very precise with your laminectomy. And it takes less than 20 minutes to complete the whole laminectomy. And this video is to show you how precise they are. So once you have gone through the ultrasonic scalpel and you have completed your laminectomy, the bone cut is so precise, it takes you another 10 seconds to complete a C3 to C7 complete laminectomy. Because, and look at it. Look at the beauty of the cuts. They're just exactly lateral to the lateral border of the dura. And because you're not going very lateral, you're not violating your facets. And look at the bleeding. Because you are not that lateral, all your plexuses, and this is the problem moment, a lot of oozing. There's hardly any bleeding in this field. And that is where we not only did this, we literally studied our first result. So we looked at the cases where we used this navigation system and those where we didn't use. And we looked at various things, not only the clinical parameters, but we also looked at the post-operative MRI CTs to evaluate the accuracy of the system. So this is like, we looked at a lot of data. We looked at how the cord diameter changed, what were the clinical results. We looked at all these parameters. If the compression was adequate, what was the pre-operative total area, what is the post-operative area, all things were looked into. These are some of the case example. And look at these facets. They're not your typical facet. And believe me, we have been doing cervical lami for many, many years. And but in cases something like this, where will you take your cut? It is very, very confusing. But believe me, in spite of everything which we did, and when we are using the navigation, we found that, and this is the case, the same case, the navigation was every time accurate. We might be wrong in spite of all our abilities and our experience to know exactly where the cervical cuts goes, but the navigation was almost 98% accurate. And this is a laminectomy and post-operative MRI after this surgery. And this is the cord compression. So another thing which if you look at is it's because the laminectomy is not very wide, it is allowing for a controlled cord fallback. The cord fallback is just enough to give you a good decompression. And look how precise those cuts are, which is very, very difficult for you as a surgeon to understand where exactly your cuts goes. And these are the other MRI scans, especially in cases like this, where you have a compression going beyond C2, we really found it to be very, very useful. All you need to do is to use navigator scalpel and simply cut through the C2. It is like, passing a knife through the butter. And the accuracy is amazing. And you know exactly how much decompression you're achieving. So this is how the whole thing looks like. And, and this is a post-op, this is an intraoperative image. And even if you have OPLL, you can just leave the sleeve off and really undercut the C2. And these are some of the post-operative images, which shows a very well done decompression. So when we looked at all the data which we got from our first series, in terms of canal decompression, both the techniques were equally good. In terms of neurological recovery, they didn't make any difference because, of course, at the end of the day, if you do a good decompression, the neurology is good. But where we saw the difference was, of course, the blood loss was less, you were much faster, and you are not going to the lateral gutter. So, you're not getting the ooze which comes from there. And we got a significant lesser number of facetal breach in navigated case compared to the non-navigated case. And even we got less post-operative complication. Now that you can question this data, but what we believe, because the cord fall, because you're not doing a wide lami, so your cord fall back is not that steep. And that is what leads to lesser post-operative complication and lesser C5 palsy. And, although ultrasonic scalpels are very well studied, and I started using it during my fellowship in Salford Royal in UK itself, and then we adopted it when I came to India. But something like this has not been studied, not been found. Even we believe that post-operative kyphosis will be less in these cases because you are doing a conservative cervical laminectomy and a very, very precise cervical laminectomy. So this was our first series to test the system and to understand how good or bad it is. We published at the award paper session of cervical spine research at Asia Pacific recently. So then we went on and started experimenting. If it can work for cervical laminectomy, why not use it to do some more challenging cases? So this guy, he is a HIV positive patient, and he has been coming to our clinic for many, many months. And every time X-ray was done, nothing was found. He was always sent back. There is nothing, just some physiotherapy, some pain medicine was given. But this is what we found when ultimately a CT was done, and this is how it is. It is a very controlled, abscess inside the spine, and this is at a D10, D11 level. So how do you deal with this? Of course, we wanted to do a biopsy. We tried doing a biopsy, but the biopsy were unfortunately inconclusive, and that is where we thought, let's try something different. So we again used the same imaging system. We merged the CT and the MRI, and look how beautiful it looks. And then we used the endoscopic navigation. We navigated our endoscopy using the navigation tracker. And this is at the end of your decompression of the lesion. And you can see how beautiful the bone looks once you have taken out that pathology from there. Not only we took out the pathology, we also could put allograft using the same navigation system. And you look how the allograft is exactly fitting into the place. The patient has a significantly improved VAS score even on day one. It turned out to be a mycobacterium tuberculosis. He was HIV positive, so it is common in these cases. And this is a post-operative CT MRI at 2 months follow-up. He is doing fantastic. So, so from this, we thought, let's do some more things. This is a 28-year female, and she has 2 levels of, she was having cervical radiculopathy for a very, very long time. And they are hard calcified disc in spite of being a 28-year female. Of course, you can say you can do ACTF, that is okay. But do you want to fuse someone at 2 levels at 28 years? So this is what we did. We use the navigation system and endoscope to track both those hard cervical discs. We could track them, we could burr them out, and that can be done using a single incision, because even before you start your endoscopic cervical spine surgery, one port can be used to tackle both the discs. And then, once you try and have good result with a few cases, we went into doing some bit complex cases as well. So this was a patient who came to us with a left-sided weakness, and this was the MRI. This was in 2021 or 22, I guess. So it turns out to be a myothelial carcinoma, which is a variant of chordoma, a very, very rare tumor to have in cervical spine. And we operated the patient. We took out the whole tumor. We went from anterior, posterior, everything, and we fixed him. And he went on to do very, very well. This is 6 months follow-up. This is a 3 years follow-up. No recurrence after 3 years. And this is how the fusion is. If you look at the lateral pillar, there's no lateral pillar left. So we have used a fibula to reconstruct the lateral pillar in this case. And this is the beauty of the body. Look at how the fibula has completely fused, and up to 3 years, all good and fine. And we also published it, of course, because this is a very, very rare case to not to be published. And then in 2025, this is how it comes to with a recurrence. Now, we had implants anterior, we have implant posterior. It's a revision case, it's a difficult scenario. So, it's not something you want to do it. Whether you go from anterior or posterior, you really will need to take out a lot of things. And, the revision surgery in a tumor is not that easy. And that is, again, we took help of the system, and we could, merge these images. We can identify exactly where the tumor is. And this is how it looks like. You can track the tumor based on the navigation and based on the intraoperative imaging. So this is, and we could drop a tube inside exactly to that area. So instead of going anterior and posterior, we took a lateral trajectory. See how lateral the imaging is. So this tells you better. So we dropped a tube from pretty lateral. We could bypass all the implants we have. And this is how the whole setup looks like. I'm looking at the navigation. I dropped a tube inside, and we could use tubes along with ultrasonic aspirator. And this is a post-operative MRI, which shows exact size and the precise excision of the tumor. And I think it will have been very, very challenging if you have done it without using the tools we had. So, this is the experience we had with MRI navigation. And I believe this could be the future. If you could have something like this, why not? It allows you to do adequate decompression. It makes the complex cases something which some of them, which I showed you, simpler. It decreases your operative time. It is likely to decrease your complication. We believe it will lead to better outcome. It will make your life easy, your patient's life easy. And that is our experience with MRI-based navigation. And before I go, I will also like to invite you and all your viewers to Minimally Invasive Spine Society Asia Pacific meet in July, which I am doing as the organizing secretary. And this is everyone who wants to know MIS, please do join us. We have international faculty lineup. We have 36 international MIS surgeons from all over the world joining in Mumbai. So hopefully we see some of you there. Thank you for having me here.
Thank you, Ayush. It was great. I think we are moving to the next presentation from Hitesh, and then I'll ask you a few questions later on if you can stay with us. Okay?
Sure.
Thank you so very much. Hitesh, are you ready? You're still on mute. You can start to share your screen.
Yes, hi Mario. Thank you very much for inviting me. I'm just going to load up. And is that online for everyone to see?
It's on and it's on presentation.
Perfect.
Yeah, so thanks very much for the invite, Mario, and honor to really follow someone like Ayush, clearly doing quite groundbreaking work in Mumbai, using very advanced technology, which is really where spinal surgery is heading. I've been given the task of presenting on degenerative cervical myelopathy, and the title that Mario asked me to speak on was on tips and tricks for anterior cervical spine surgery. And I've sort of gone slightly off what you would normally anticipate with this type of talk, which you'd normally think this would be really much orientated around the surgical practice of managing cervical myelopathy through an anterior approach. But I think a lot of the decision-making and the management with respect to tips and tricks comes from the preoperative planning, comes from the decision-making that takes place outside of the operating theatre. Yes, the practice within the operating theatre is crucial to surgical outcomes, but the preoperative decision-making is equally valuable. So no conflicts of interest on my part. Any imaging that's been used has been approved from the relevant patients. So degenerative cervical myelopathy, essentially, sorry, I'm just going to... So essentially, it's a terminology that's really been brought to the fore recently by the work done by the AO Spine Recode group. And they've brought together many terms that were essentially used to describe the same type of pathology. So people who'd use cervical spinal stenosis would use cervical spondylitic myelopathy, would talk about OPLL, and what they've brought together is a single unifying term for a progressive spinal cord injury secondary to narrowing of the spinal canal. And they did this through a validated global multi-stakeholder modified Delphi consensus process. We know that cervical myelopathy is a common problem. It's probably becoming more commoner because we're learning to pick it up a lot more quicker. Subspecialties that work alongside spinal surgery, such as neurologists and rheumatologists, are also on the lookout for it. And the average incidence is estimated to affect about 1 in 50 adults, with the incidence and prevalence in North America being 41 and 605 per million respectively. This is a diagram that I've taken from an article published by Neuric, which effectively shows the pathogenesis of cervical myelopathy. And it's quite a complex process involving the formation of anterior disc osteophytes, retrolisthesis of the vertebra, thickening of the ligaments, and also you can have features of instability across various segments of the cervical spine. And so how does it present? Well, there's a multitude of symptoms that it presents with. It's effectively a syndrome. So you don't necessarily need to have all the symptoms. You can maybe have some of them, or you can have a combination of them. So generally, patients can present with neck stiffness, neck pain, radicular pain, problems with doing things with their hands in terms of fine tasks, opening jars, doing up buttons. I've recently had a patient who went and changed their wardrobe, went and bought shirts and blouses with bigger buttons because they were having problems with finer buttons. Often patients have problems with their gait and they may report some falls. Other conditions that can present with similar symptoms are those that have been described there on the screen. So it's quite an interesting condition in terms of the fact that the symptoms do overlap with other conditions, both in orthopedics as well as in neurosurgery. It's important to clinically assess the patient. So there are Michael Failings' groups have published recently in the Global Spine Journal specific myelopathic questions that you should be taking as part of your history to try and help determine whether this patient's presenting with myelopathy and what the extent of myelopathy is likely to be. All patients presenting or going on to have treatment for cervical myelopathy should have a modified Japanese Orthopedic Association score carried out. It's a relatively simple score to carry out, as illustrated there on the right-hand side of the screen. And imaging, well, the gold standard is MRI. And an MRI scan will help you determine the level of compression and whether multiple levels are involved. It will help you identify where the compression is. Is it anterior to the theca or posterior to the theca? Are there any features of cord inflammation, myelomalacia, best demonstrated on STIR sequencing, but also hypointensity on T1 sequencing is a bad prognostic factor. Patients may not necessarily just be presenting with myelopathy. They may well be presenting with a combination of myeloradiculopathy. So an MRI scan is useful in being able to assess the degree of foraminal stenosis. Are there any features of adjunct pathology, such as a syrinx? And an MRI scan also can give you some additional insight into the vascular anatomy, whether or not there's a particular predominant vertebral artery. Sometimes there can be an aberrant course of the vertebral artery where there is a vertebral artery that's coursing into the disc space. Additional imaging modalities which can be useful are CT scans. CT scans generally help with your bony planning, determining the degree of OPLL, if there's anything present, and also to help determine the degree of foraminal stenosis. Plain radiographs are also useful to determine alignment and instability. And the series of imaging that I demonstrated up here demonstrates that an MRI scanner can help you identify pathology anterior to the theca. It can help you also determine the degree of cord compression at that level. Now, other forms of imaging parameters that are useful is to try and use the K-line. And the K-line is useful in determining whether the pathology is anterior to the K-line or posterior to the K-line. More recently, increasing work has been done on the use of sagittal parameters. More work has been built on from the work that's been done on lumbar spine with pelvic incidence and lumbar lordosis. And now routinely more and more people, when they are assessing patients with cervical myelopathy, should be looking at the cervical alignment in terms of the SVA as well as the T1 tilt. The illustration on the bottom screen on the right-hand side demonstrates a CT scan, and I tend to favor doing a CT scan for most of my patients with myelopathy as it helps me categorically rule out any features of OPLL. Now, in terms of determining the surgical strategy, essentially is broadly based into either an anterior approach or a posterior approach or a combined approach in some settings. I think the approach should be tailored to individual patients and shouldn't be rudimentary and should be based on radiological features as well as the K-line. And so why would one want to choose an anterior approach? And I think this can be broken down into three essential categories: pathoeconomic factors, patient factors, and surgical preference. So pathoanatomic factors, generally, I would say that if the pathology is limited to 2 to 3 levels, then an anterior approach is generally favorable. If the pathology is anterior to the K-line, and if the spinal alignment and the sagittal parameters are favorable. So this workflow diagram that's recently been put forward by Dan Rue in an article that he's published last year provides a framework in which one should think about which approach to consider for a patient. And also for me, if there's the absence of posterior longitudinal ligament ossification, then I would prefer to go with an anterior approach. Now, in terms of the patient factors, I would previously people have considered age as a consideration, and I would probably say that age, I was always taught, was an important factor, and that they would say that older people don't tend to favor anterior approaches to the cervical spine. However, in my practice, I've tend to steer away from that because I still feel that if you plan and work your approach carefully, and an anterior approach in an elderly patient is still well tolerated. Medical comorbidities. So we know that anterior approaches are associated with lesser risk and rates of infection compared to posterior surgery. So in patients that have a higher risk of infection, an anterior approach may be more favorable than a posterior approach. If somebody's had previous neck surgery, if they've had radiation, that may complicate why you're not able to do an anterior approach. And also bone quality is important. So if you're planning on putting in instrumentation, certainly if you're planning on using a plate anteriorly, you'd want to know if the patient has any features of osteoporosis. Also, if you're using posterior instrumentation, then you'd want to determine whether or not your screws are going to be sufficient, have sufficient bone hold, and that can be assessed through things like a DEXA scan. Most surgeons, certainly most fellowship-trained spinal surgeons, should be comfortable with an anterior approach to the cervical spine. And what's the evidence for anterior versus posterior surgery in cervical myelopathy? Well, the largest randomized controlled trial from Gogolwala, which was published in 2021, has effectively shown that there's no advantage in terms of the outcome scores, in terms of functional outcome, as well as radiological outcome for anterior over posterior spine surgery. A further meta-analysis done in 2023 by Satari's group also found no difference, but there was a subset of patients who if you analyzed, that there was some benefit in terms of SF36 and quality of life function scores. More recently, a publication that's in print from Michael Failings' group that's due to be published looked at 3 large clinical studies and did a prospective analysis of three of these studies. And In their analysis, they found that statistical significance was, sorry about that, someone's just actually trying to call me in my clinic room, but they found that statistically there was a significant difference in an anterior approach versus a posterior approach when they looked at the neck disability index as well as the SF36 MCS scores. Now, the aims of anterior cervical spine surgery in DCM is effectively to decompress the spinal cord, to provide stable instrumentation, and to avoid complications. And if you're aware of the complications that can occur, then in terms of your preoperative planning, you're more likely to put things in place that would minimize those. Perioperative setup is very important. So for me in my practice, we have a multidisciplinary team, and we have a consistent team doing the same procedures on a weekly basis. It's important to ensure that the patients with cervical myelopathy are carefully positioned, and that's carefully positioned during anesthesia. So during an intubation procedure, it's important that the patient has inline immobilization or fiber optic intubation is used. The patient is carefully transferred in my hands by myself onto the operating table with inline immobilization, and I generally tend to favor using a head ring and using sleep tape to tape the shoulders down. In some patients, I will consider using a Mayfield clamp, and those are patients in whom I am operating at the lower cervical levels and they've got large shoulders, and I really want to pull down on the shoulders in order to be able to intraoperatively visualize the levels that I'm planning to operate on. It's important to have an optimal workflow. So in my operating theatre, I tend to have a microscope, I tend to have the image intensifier coming in from the top end of the patient, and have the anesthetic machine at the bottom end. It's important that the anaesthetist uses a reinforced endotracheal tube, and it's very important that a discussion is had in the team brief beforehand that the anaesthetist is going to maintain an adequate mean arterial blood pressure. Now, mean arterial blood pressure in some of the scientific literature is quoted at, well, we should be aiming at something around 80 to 90 millimeters of mercury. Now, that's a broad figure that most people will tend to follow, but I think it's very important to tailor that to the individual patient. And in my practice, I tend to recommend 10 to 15 millimeters above the map. It's important to remember that in cervical myelopathy, patients are generally a lot more hypertensive because the compressive pathology does affect the sympathetic nervous system, which can make them hypertensive. So actually not being aware of this intraoperatively and working at a lower map can sometimes lead to adverse outcomes in patients. Use of steroids. I think a lot of the discussions about steroids in spinal surgery has come around spinal cord injury. But in terms of my practice, my anaesthetists tend to give patients 6.6 milligrams of dexamethasone as part of the induction algorithm. And 6.6 milligrams of dexamethasone, I've been advised, is equivocal to about 30 to 40 milligrams of hydrocortisone. So I think that does provide some neuroprotection in terms of minimizing any risk of reperfusion injury, but also the steroids will help with minimizing any perioperative swelling related to retraction. Magnification is an absolute in my practice, and I tend to favor a microscope, both in terms of the magnification it provides as well as the illumination, but it also allows my assistant to be able to see what I'm doing as well as the wider surgical team. Intraoperative neuromonitoring, I don't tend to use that as part of my practice. I think the scientific literature is still up in debate as to whether or not there is a role for it. I think if you're doing deformity correction, it's a must, but certainly for straightforward myelopathic cases, I don't tend to use it. In terms of the technical tips that I can impart on the audience, well, I think the surgical approach is the key, is having a knowledge about that is key, and having a working knowledge of the anterior cervical anatomy is also crucial. If you're aware of the structures that can be at risk during your approach, then you're less likely to injure them. I tend to mark my patients before I start. So I mark the midline, I mark the medial border of the anterior sternocleidomastoid muscle, as well as marking the clavicle and the manubrium. And it just provides me with a reference point intraoperatively as to where I am when I'm placing my cages. I mark the periphery and the boundary in order to allow for my scrub nurse and assistant to drape the patient. Prior to undertaking the surgery, I do a level check using a metallic device placed superficially on the skin. And then as you're progressing intraoperatively, understanding the three key fascial layers, the superficial cervical fascia, the deep cervical fascia, and then the longitudinal fascia. once the superficial fascia has been carefully incised, it's important to palpate the carotid. Now, the AO website talks about using manual retraction to work yourself down. I think that's part of the approach, but it's also important to use careful retraction in order to ensure that any bridging veins and vessels are protected and any neural structures are visualized. It's important also to visualize the omohyoid, and certainly if you're doing a 2 or 3 level ACDF in the mid-cervical region, this structure can be carefully dissected and released. I tend to favor releasing the prevertebral fascia under direct vision and exposing the levels just that you need to expose for your surgery. In terms of placement of retractors, I think this is very important after the levels have been marked, and I tend to use bipolar cautery to elevate the medial border of the longus coli, and then to use a McDonald's or a Cobb elevator to gently elevate. I try to avoid using monopolar because of risk that it may have to any adjacent structures. And then after that, it then comes down to careful surgical technique, controlled use of instruments during the procedure. When I'm doing my decompression in front of the spinal cord and taking the PLL down, I will use nothing more than number 1 kerosene, and that will have been done after I've carefully used a high-speed burr to thin the posterior osteophyte. Once the posterior longitudinal ligament is taken down, then you've adequately decompressed the theca. It's important, if you do have features of foraminal stenosis, to carefully decompress the foramen as well. During the preparation of the disc space, it's important to respect the end plates, because this is what will support your instrumentation. And then the implantation of the instrumentation should be done carefully and using fluoroscopic guidance. The choice of instrumentation is up, really, I think it's up to the individual. And I think if you're doing a single or 2 level procedure, I think standalone interbody cages are appropriate. You can use integrated interbody cages if you want a little bit more stability. And often some patients may benefit from using an interbody cage and a plate. I was trained as an orthopedic surgeon to use an interbody cage and a plate, because you're always taught that stability is important in orthopedics, and that this is best achieved using a cage and a plate. But I think using plates can provide a higher risk of complications associated with postoperative swallowing difficulties. And if you're placing a plate, it's very important to respect the adjacent disc spaces and not to encroach on those disc spaces, as that will potentially increase adjacent segment degeneration. The use of cervical disc arthroplasty is being debated more and more in the scientific literature, but it's not part of my practice, and I would generally favor using a fusion modality as opposed to a mobile disc, as well as opposed to something that's going to preserve motion, such as a total disc replacement. So thanks very much, everybody. Just hand back over to Mario.
Hitesh was fantastic, very clear as usual. I would ask you only one question, and then I know you have to go. Can you please tell us if you have any experience on endoscopic C-spine surgery, or if it is something that you are planning to develop in the future?
I've not had much experience in that, Mario. I have seen more and more articles in the literature. Certainly in the Far East, there's a lot of work on endoscopic spinal surgery for myelopathy, certainly for anterior procedures. But I don't know whether anyone else on the panel, such as Ayush, because he's got a very vast endoscopic practice, whether or not he has experience in that.
Hitesh, can I just ask you a few things?
Yeah.
Yeah. So great talk. And it's so funny that I completely agree with you on the point of mean arterial pressure, the MAP, so much so that we published our work in Global Spine Journal, and we said exactly what you quoted, that MAP should be individualized. It cannot be random 80 to 90. In our series, the mean MAP from the patient was 95. So if you keep them at 80, actually you're making them hypotensive. So, we recently published in Global Spine Journal, and you can look at the paper. So, I just wanted to add to it that, and other thing, and we have quite a bit of work in myelopathy as well. And there is another thing which we really believe should be tried, and we feel it works, is a drug called cerebrolizin, which I don't know if you have heard of it, but we have published 2 papers in Spine Journal on that. And we, as a protocol, give it to all our cases of myelopathy, and we believe it has a neuroprotective effects. And as you know, decompression is just decompression, but we are not doing anything to revert back the things which are already happened. And that is where we believe the cerebrolizin comes into picture.
It's very useful.
Thank you, Hitesh. Thank you, Ayush. I think we can move forward to the next presentation from Iago. I can already see his light on. Hitesh, I know you need to go, so thank you very much for your presence.
Thank you very
I
much.
wish you a good rest of your afternoon. We'll be in touch soon. Thank you, Hitesh. Bye.
Hello, everyone. Thank
Hello,
you, Dr.
Iago.
Mario.
Thanks
Thank
for
you,
coming in. So let me introduce you briefly. Iago is the head of neurosurgical department in Kutaisi, West Georgian Medical Center. He's also associate professor in the local university, and is the national delegate for Georgia at the EANS. We share a very long friendship. I've been visiting him in Georgia when we had the first Georgian Neurosurgical Society meeting in September last year. I think Iago is a rising star in neurosurgery, and I would be very happy to hear your talk. Iago, please go ahead.
Thank you for your kind introduction, and thank you for your kind invitation. Thank you for this type outstanding presentation from Dr. Ayush and from Dr. Hitesh. My talk is about how I do extraforaminal lumbar disc herniation. As already Dr. Mario mentioned, I am a neurosurgeon, and also my practice is to do spine cases. As everyone knows, bilateral disc hernia resulting compression of the nerve root in or lateral to the intervertebral neuroforamen. It occurs in about 10% of all symptomatic annular prolapses or disc. Most commonly, bilateral disc herniation occurs L3, L4, L4, L5 or higher levels. They occur in about like equal numbers at L3, L4, and L4, L5. About half that is L5, S1, and in small numbers is upper levels like L1, L2, and L2, L3. Lateral hernia occurs also in older patients more often than young patients. Radiculopathic pain, radiculopathic pain may be more severe, and back pain less severe than that incurred in paramedian disc hernia because of the location of the sensory root ganglion, more likely to produce a sensomotor deficit. What's the indication of the surgery? Indication of the surgery is the same as always. It's a failed aggressive medical management, including non-steroidal anti-inflammatory drugs, physical therapy, and epidural steroid injection. Also, progressive neurological deficit is one indication of surgery. What's about of approach? Several surgical approaches for the bilateral disc herniation have been adopted and described over the last 20 years. Conventional midline approach often utilizes a large laminotomy and partial facetectomy to expose the herniated discs for surgical removal. However, this approach may lead to intersegmental destabilization of the lumbar spine and maybe contribute to the chronic back pain postoperatively. Watkins in the 1953 described the paramedian approach that was later modified by Wilze. And everyone knows this approach when we are splitting paraspinal musculature and preserve the facet joint to assess foraminal and extraforaminal regions. In the last 3 decades, increased awareness of motion segment instability and chronic lumbar back pain, which are attributable to the facet joint disruption, has generated a growing body of literature advocating for a paraspinal approach. That's why maybe mini-invasive approach is more popular nowadays in terms to preserve motion and preserve to avoid segmental instability. The more recent advent of MIS surgery embraces the use of tubular retractors as further enabled spine surgeons to approach the extraforaminal region with a minimal disruption of the stabilizing tissues of the lumbar spine. As we know, there's several type of approach. I would like to show you more. Very often we are using two approach. Like one is a classic approach when dilatator is set. It's the insertion of the transverse process with the superior articular facet of the inferior vertebra. Then the inferior pedicule can be palpated. The disc is exposed, firstly, and the exiting nerve root located at the cranial part of the tube. It's not necessary to expose. Second one is a cranial to caudal. Also, we know this approach like a top-down approach. The tube should be docked on the pars interarticularis, the ligamentum flaum. The ligamentum flaum at the cranial aspect of the foramen is removed, and the bolty probe is used to palpate the upper pedicule from below, that allowing to locate the root. Once the root is exposed, the disc located caudally could be approached safely. What's about instrumentation of tubular discectomy? It's you can see all instruments what we are using during this type of surgery. Also, Wilson frame is I think mandatory to do this type of spine surgery. Familiarity with the microsurgical anatomy of the far lateral compartment is essential for operating in the patient with far lateral discs. In this nice article, author described microsurgical anatomy in cadavers. As you see here, you can see nice anatomy of spine. You can see medial part of pars interarticularis. Laterally is the medial free edge of the transverse ligament, inferior aspect of the superior articular process and the inferior articular process. The dorsal root ganglion was located with the foramen just inside the lateral border of the pars interarticularis, and the posterior ramus of the lumbar spinal nerve arose immediately distal to the dorsal root ganglion. The posterior ramus divided into the three distinct branches. A medial branch was closely applied to the facet joint. Also, I would like to show you vascular anatomy. The segmental lumbar arteries supplied muscular branch to the psoas muscle before entering to the foramen. I would like to show you one small short video. If you look at yellow arrow, you will see where the root compressed by the herniation. X-ray you can see. Now after that I would like to use X-ray. X-ray fluoroscopy is then used to identify anatomy, and then 2 centimeters paramedian incision is made. We have dilated with up to about 16 millimeter dilatator, and then put over 80 millimeter final tube. After the final tube is placed, as you see here, we would like to take again X-ray to demonstrate our tube proper position. Now I'm going to use a special retractor, but anytime if it's necessary, I can change position of tube. Then I am starting to use microscope and identify normal anatomy. Monopolar is used to identify normal anatomy, including the medial aspect of the transverse process, lateral aspect of the pars interarticularis, inferior articular facet, superior articular facet and facet joint line, as you see here. The lateral facet of the foramen is palpated and enlarged using the high-speed drill. And after actually ongoing hemostasis is secured with bone wax or some hemostatic sponge. Now I'm going to use a Carison upcut to remove part of ligament flow and facet joint capsule. Now you can identify perineural fat. With my left hand now, I would like to use it's actually left side far lateral disc herniation. I would like to use a left special suction with special retractor. And now you can see extraforaminal part of nerve root. Now I'm going to using my special hook to identify fresh fragment. As you see here, and you can see this small fragment. Even this small fragment is enough to have patient severe pain. Sometimes I don't like to do annulotomy, but in this case, I have used microblade to do annulotomy and created space to provide and open disc space and remove some underlying disc fragment in terms to reduce yearly recurrence. But I'm not sure if it's always necessary. I'm going to remove some part of disc. And so there is no big evidence, but I would like to use a long-active steroids in terms to decrease after root retraction, to decrease inflammation of nerve root. Okay, thank you for your attention. I would like to invite you in July 2025 in Mumbai. There will be a big event. Dr. Ayush will be host doctor, and will be a big event about minimally invasive spine surgery. Thank you again for your kind invitation.
Thank you, Jakob. It was really a nice presentation, a very good anatomical rationale and great example. And obviously, thanks for reminding this invitation to the conference in Mumbai this summer. Ayush, are you back with us?
Yeah, I'm still there.
So let me start with a question for you, and then I'll ask also a question for Jakob. The question regarding the first question is regarding the use of neuronavigated ultrasonic cutter versus high-speed drill. My trainees know that when I do a C-spine laminectomy, I always prefer ultrasonic cutter for the laminectomy stage. It gives a very clear surgical site. It does not cause excessive epidural bleeding. What is your experience on both of them, knowing that at times there might be difficulty in navigating the drill, whereas the ultrasonic cutter might be very useful also in the case just described by Jakob?
So I believe ultrasonic scalpel, by the technology itself, it is not a mechanical device. So your burr is a mechanical device. You're cutting by the rotation, and that itself has its problem. While the ultrasonic scalpel cuts the bone through a different technology altogether. It uses the ultrasound at a specific frequency to go through the bone. By the virtue of it, it makes it more safer. And at the same time, it also is very, very precise. So although both can be navigated, navigating ultrasonic scalpel might be slightly cumbersome, but if you use too good technology, you get the best out of it. And that is where I believe. Of course, a navigated drill is equally useful, but I think, and we have used both, and I believe if you can navigate ultrasonic scalpel, it is like, it is really, really helps you, especially in your difficult cases. Like that has been our experience.
The second question that I have goes back to what I had asked to Hitesh regarding the use of an endoscopic surgery. You're very experienced in the use of endoscopic surgery for both mostly in the lumbar spine, but also in thoracic spine. Are you employing it also for C-spine pathologies?
So yes, but C-spine pathology is different, and you have to be very careful to choose the right indication. So you can do it, but understand, just because you want to use endoscopy doesn't mean you do a half job. You cannot do that. So you have to take it carefully. We use it in some very specific cases, like the one I showed you. Like if you have a forearm, you don't want to do a foraminectomy or a lateral disc. It's the most beautiful thing you can do. But you want to try it in myelopathy, you need to take a step backward and think twice. Maybe someone who is very expert might get away with it, but you have to understand your limitation. You have to understand the limitation of the technology and use it wisely, and that is all that matters.
Yeah, in my view, the role for endoscopic C-spine surgery would be mostly for foraminotomies or for as an adjuvant to microsurgical technique in ACDF. Might also be very useful to look around the corner, and I mentioned this particularly for the trainees. If you're doing a lateral approach to the C-spine, like an oblique corpectomy, certainly there is an argument of bringing in an endoscope to look around the corner to make sure all the vascular structure and neural structure remains intact. But I think the take-home message is precisely what you said. You need to be careful in the indication, because otherwise you risk to run in difficult waters. Absolutely. So I do not have any other question for Ayush. Yao, do you have any
I'd love to
question?
ask Ayush a question. Ayush, thank you so much for your talk on the navigation. It was very inspirational and very lovely to see some of your caseload. I would like to ask you about the registration time when you include the MRI as well. How long does that take on
It takes
average?
around 5 to 10 minutes.
Yeah, because it was very interesting because I was prejudiced. I actually thought that your operating times would be longer with the navigation. It was quite pleasing to see that you had quite significant improvement in your times with the navigation. That gave me some hope. Okay, so 5 minutes. And is it Brain Lab you said you're using mainly?
Yeah. So
Okay,
it is a brain lab system. Please understand, if you use navigation once in a while, you will have a higher operating time because your team is not used to it. But if you're
of
using it
course.
every day, you will suddenly see your operating time is less, your team is faster, and everything is simply fills into place. And that is how it is about any technology which you use.
And just about your kit, because it was quite interesting case mix you showed us with the navigation, which was quite lovely to see. Are there cases where you think navigation is now, from your point of view, essential? And I'm not talking just about screws and so on, because I saw you had the very interesting high, it's quite severe myelopathy in the case you showed us there. Are those the kind of cases you just would do it for? Always?
Yeah, so now anything we found out of ordinary, like if we find is a challenging case, it is something which guides you. See, the basic principle of spine never changes. We do exactly the same thing which we do, but if you have something which allows you to look at a real time MRI imaging or navigate based on that, why not? It makes things easy. You're not simply assuming there's a nerve, there's a cord, it is a tumor. You can see exactly where it is. Of course, every technology has some margins of error, but as much as you can use it to give the safe result, why not to use it?
I would like
agreed.
I would like to add something. Actually, I had the opportunity to visit Dr. Ayush. It was like 3 years or 4 years ago, and it was after when I have backed it at my home, in my university, in my hospital. We have started to use tube. We have started to use my spine, and actually, it was really outstanding and brilliant what I saw during the visiting in his department. Really, I would like to add one comment about C-spine endoscopy. What I saw during my visit, he's using It's endoscopic spine for young patient to do fragment sequestrectomy, and it's really I think very crucial and benefits. There is some benefits in terms of young population. No, nowadays I'm not doing endoscope, but I think it's one indication for C-spine.
Thank you, Yakov. Thank you for the kind words. You're always welcome, and it was a pleasure hosting you.
And I know that the two of you were organizing the spine course in Kutaisi recently, right, Jakob?
Yeah.
So certainly there would be more opportunity for collaboration even in the future. Going back to the case that you presented, Ayush, the one on the myoepithelial carcinoma. I understand this is a primary lesion, is very rare, but it originates from salivary gland cells mainly. So effectively, it's not a primary bone tumor per se, and that's what I wanted to underscore, because effectively the indication in the approach that you have followed, so the two-stage surgery was the most correct one and the safest one, because an en bloc surgery would have not been appropriate for this patient and most likely would have been too risky. So I just wanted to clarify that it was important to establish the diagnosis, and then the two-stage approaches, anterior and posterior, from my point of view, was the most correct approach. And I understand this was published on John Bond surgery, right?
JBJS, yeah.
JBJS, yeah, okay. Fine. I do not have any other comment. I would like to bring in Professor Sirmos for the closing remarks. Nick, are you happy to intervene?
Mario, thank you very much. Here we have the masters of spine surgery across Asia and Europe, such as Ayush Sharma and Jakob Cervadze. Jakob, it is also a spectacular vascular neurosurgeon.
That's true.
I want only to mention that in Europe, we have to face every time geriatric population over the past of the years. And I don't know if these techniques have a good relevance in geriatric people, because sometimes we have to reoperate, especially in lumbar spine. I want, if we have time, a short comment from Ayush and Jakob about when we face geriatric population. Technology is it's very useful. Perhaps in the near future, we will be also the assistants of technology much more than spine surgeons or neurosurgeons. This is a useful topic, and perhaps also for the young generation. Compliments. The speeches are really good and are valuable also for a World Spine Conference or something like that. Thank you very much.
Thank you.
So, from my point of view, I would echo what was described in a couple of presentations, particularly by Tesh, but also by Ayush, and in some parts also by Jakob. Age might be a confounding factor. I think we should move from considering age as a risk factor and consider frailty as a risk factor. And since the two coexist, obviously, you might risk to mislabel what you are referring to as the driving forces for some complication. I think frailty is more relevant than age per se, and I believe this has been highlighted by multiple presentations today. And then I agree with what Nick said. The use of technology can certainly facilitate our approach to several challenging scenarios. I don't think there are any other questions from the attendees. So yeah, thank you so very much for being with me and sharing this session. I think we had
Pleasure.
wonderful speakers. Ayush, thank you so very much for getting engaged with us. Jacob, thank you so much. Hitesh had to disconnect, but I'm very pleased that we had on this spine talk good contribution from wonderful orthopedic spine surgeons. I'm blessed to call you friends, and Jacob, who has been a wonderful faculty speaker today. Thank you so very much, guys.
Thank you. Bye-bye. Thank you. Pleasure.
Yeah, I'd like to thank
Right.
all the panelists and Mario for putting this all together. It was a good interactive webcast that benefits everyone. And thanks for dedicating your time. And we'll see you at the next webinar.
Bye-bye.
Bye.
Bye-bye.
Bye.
Okay.